We've done this now. I think this is the 4th episode of Report Pending, and we're kind of modifying it as we go based on feedback that we're getting from folks that have joined weeks past. It seems like what we're enjoying is a mixture of maybe known cases that I've gone through and some unknown cases that we pull off the list. I read some cases today that we can go over that I thought were kind of good. We've had some requests for musculoskeletal. Thoracic radiographs always seem to give people a problem. So feel free to keep making suggestions. You can email me. Most of you have my email. The other thing that you can do if you're brazen enough is if you have any cases of your own that have stressed you out or given you fits, you can bring it here and we'll jam and figure out what's going on, and I'll tell you my opinion. So I see a lot of times on these Facebook groups, people are putting help, whether that's because they don't have the funds to get the case read out by a radiologist, or perhaps the turnaround time is too long for it to be clinically useful. So sometimes I think those could be great cases to teach on, especially if the quality of the study is good. So feel free to email me with those. All of the live streams are going to be lightly edited and then pushed to YouTube. We had 7 views over the weekend. That's right, 7. So for the 3 people that actually watched it, thank you very much. The other 4, I'm sure it was an inadvertent click. So we're booming. YouTube, 7 views. Okay. Let's see if we can get 8 views by the end of the week. So here we go. I'm going to start with the case that I just read. And as usual, what I'll do is I will give you the brief history, the signalment, and then maybe pause for 45 seconds to a minute, thumb through the radiographs to give you guys an opportunity to formulate an opinion, and then I'll kind of tell you what I do and what I diagnosed. All right, so here we go. Okay, so we've got a geriatric, it's like a 14-year-old chihuahua that is tachypneic and coughing. And then as usual, I like to flip through and make sure I know what I'm dealing with here. So we've got 3 thoracic radiographs. Okay, so good luck. Let's see if you have any idea what's going on. A couple of things that you kind of want to, a lot of times when these respiratory dogs come in, respiratory cats, you want to make sure, am I dealing with a cardiac problem or not a cardiac problem? And so I think that this is a great example of a not cardiac problem. So I'll just tell you the rigmarole that I go through. So the first thing that I saw was a gas-filled stomach, like Dr. Allen pointed out. So it's probably an aerophagic component because we've got a patient with respiratory signs. This is always something that troubles people. Everybody thinks that there's a tumor or a ball foreign body, but that's probably on the right lateral view. You see when you flip the dog over, it kind of goes away. So that's probably a little bit of fluid in the pyloric muscle on the dependent side or the down side. And then when you flip the dog over, you get a gas-filled pyloric antrum coming out at you. So that's nothing. The cardiac silhouette is the gastric axis is tipped a little bit cranially, but then there's probably adequate liver. The next thing I noticed was this little bit of vague mineral right here. And I was trying to figure out, is that associated with the rib? Could it be the liver, the gall bag? And I wasn't really sure because I couldn't see it over here. The next thing, the cardiac silhouette is normal. Okay, so there's no left atrial enlargement. The thoracic trachea is not deviated dorsally. It's not particularly wide. Last time we talked about if you have a right-sided cardiomegaly, the apex of the cardiac silhouette on the right lateral view tends to tip up. So normally, you can't see it this well. I can show you in other patients because of the lung pattern, but normally on the left lateral view, the cardiac apex is deviated dorsally from the sternum, but usually the apex is sort of in close contact with the sternum on the right lateral view. So when you see it tip up on both lateral views, it's game on for right-sided cardiomegaly, but there's no 2 to 3 o'clock left auricular bulge. So the next thing is the lung pattern. And we talked last time about bronchial patterns and so on. But this particular case, I do think has an unstructured interstitial pattern. And there's not too many causes for that. Usually it's because of overlying fat. and it's just sort of a fake out lung pattern, but this patient is not particularly fat, so I think the lung pattern is real. I do think that there's some bronchial markings and some lines that come out. So I'm worried about a diffuse unstructured interstitial, sort of bronchointerstitial pattern. It does get a little bit patchy in some of these areas, like here, maybe over here. So I think there's probably, I diagnosed a diffuse unstructured interstitial to bronchointerstitial pattern. It may be complicated by some low-grade pneumonia. It's kind of real robust in here. Yes, that's a rib, but I just thought maybe it was a little bit too patchy. Differentials for that could be allergic bronchitis, idiopathic pulmonary fibrosis. So immediately when you start thinking about things like chronic lower airway disease, especially if you start thinking of idiopathic pulmonary fibrosis, the next thing you want to go is, hey, does this dog have evidence of pulmonary hypertension? So you think, do I have a 1 to 2 o'clock left main pulmonary artery bulge to the left of midline on this VD view? This is the descending thoracic or the aortic arch coming around, and the descending, and you can follow it all the way into the abdomen. And that's how you know that's the ascending. That's the aortic arch, not the MPA. So you got this diffuse unstructured lung pattern. You start going, wow, is this pulmonary fibrosis? And then you think, next step is, does the dog have right-sided cardiomegaly from chronic pulmonary hypertension? And I don't think so. Would we be surprised if he did? No, because thoracic radiography is not really good for that. The next thing to draw your attention to, which I think is a really great example, is you don't want to get this satisfaction of search where you think you found the cause for the patient's tachypnea or coughing or presenting complaint, and then you stop looking. And so if you look right in here, you've got the trachea or the trachea for those of you coming from the UK. And as the trachea comes down here, you'll notice that we call it the pencil sign, just sort of anecdotal thing, not published. But you look here and look, the trachea just blows, and the carina in here and the principal bronchi. So when you compare this view, if you look right here to that view, this view and that, like the eye exam, this, you'll notice that is completely smashed on that left lateral view. And you will get a bit of motion in health with a normal bronchial cartilage with an expiratory radiograph. A nice study came out and showed that, and we'll see it on CT a lot. But the degree of change, I think, is way too much. So this is a dog that I would be concerned has bronchial collapse. And when they're expiratory, we do appreciate intrathoracic narrowing of affected airways. Big concern here. So diffuse airway disease, maybe a component of bronchopneumonia, and then its neck is trashed. So all these disc spaces, they're just collapsed, sclerotic. There's maybe mineral over the intervertebral frame, and you can see it over here. That's that. Any questions, concerns, comments? What caused the bronchial collapse? So in that particular dog, my guess is it's a chronic inflammation, just weakens that cartilage. And over time, it loses its integrity, and then you'll get collapse. I wouldn't be surprised if the trachea also had some involvement as well. But a lot of times we will see that they can have principal bronchus collapse sort of right at that hilum. You'll see that as well. And the next one usually goes like a left cranial lung lobe. You'll see lobar collapse. Sometimes that'll trick you into thinking the dog has pneumonia when it's kind of collapsed. So I think that dog has probably bronchomalacia or chondromalacia from chronic inflammation. I don't know if that answers your question. Tom. But that last case, I guess I could pull it up, is another great example of how you could attempt, if you really wanted to, without fluoroscopy, right? So fluoroscopy, everybody says, just do fluoroscopy. Well, who's got fluoroscopy, right? Not many of us. And so what you could try to do, it's also a pain in the ass, and the technicians will hate you, but you could attempt to get them to compare peak inspiratory and peak expiratory thoracic radiographs. So if you try to get the dog to create that sort of dynamic influx and outflux of air, you could get lucky and get that collapse caught on the still radiograph. So let's see. Oh boy, we got some good ones. There's some good ones here. So here we go. Not this one. Here we go. Okay. So this is a geriatric dog as well that is presenting for a Met check. So we've got 1, 2, 3, 4, 5 radiographs. This is a geriatric dog. The owner is concerned. It's a geriatric Labrador. Owner is concerned because they felt a mass on one of the back legs, and they're worried about it. It's getting bigger. And so we've got a big mass, back leg, old dog. Oh, no. And we're going to do a MET check. So we've got some thoracic radiographs, and we've got some pelvic limb radiographs. So I'm going to give you a little bit more time for this one, just because there's 5 views, but I think this is a great case. Here's what I'll do. I'll go through the chest. So on the chest, this is how I described it, and this was done. You can see the timestamp. This came in this. Well, I just read it, so it's a little bit old, or they just submitted, I think, yesterday. But it's a newer study. So, yeah, I'm glad that Dr. Walsh brought up the right atrium, because a lot of times I think it's important for our reports to give you pertinent negatives. So say things that I think you're seeing that I'm also seeing, but that I'm not particularly worried about. So this isn't the best example, but I described this atrium, this right atrial region in the report, because I thought it would give somebody a fit, and especially because they're doing a MET check. So the first thought is, well, is this like a right atrial hemangiosarcoma? Maybe we're dealing with a subcutaneous hemangiosarcoma in the pelvic limb. But I think this may actually be fat. So my first thought was fat. The second thought was, could it be something else more sinister? Isolated. So the differentials: isolated right atrial enlargement from tricuspid valve disease is uncommon. Usually, you get if you're going to cause distension or eccentric hypertrophy of the right atrium, eventually you get eccentric hypertrophy of the right ventricle. So you have more of a whole right side component. You don't just get right atrial enlargement. And so a valvular endocardiosis would be a less likely consideration. You can have things like aneurysms of the right auricle, but that usually comes up here and is a good differential for a craniomediastinal mass, not a bulge in the right atrial region. So my guess is this is fat, probably fat and more fat, and it feels good to say that it's adipose tissue because the dog's got a decent amount of it. I don't really get anything unusual here. I think this sort of space or gap here is, again, it's a fat thing. So I like that we brought that up. Yeah, the heart, I think, just kind of looks, right lateral views, it tends to look almond shaped like that. And then left lateral views, it tends to look a little bit rounder. But I think it's totally fine. This is all cardiac silhouette apex. This is fat. This is lung. So if you drop the VHS, hopefully you guys know how to do that. But you could go from here to the apex, and then you go perpendicular here, and then you start at 1, 2, 3, 4, and you go across. And there's such a wide variety of normal VHSs that it gets a little bit exhausting trying to keep up with them. But this cardiac silhouette is normal. I described it as normal. Well, I described the right atrium as a bit of an unusual shape, but that I didn't think that it was clinically relevant. If for some reason they found a murmur, muffled heart sounds, or some sort of distant primary issue, then maybe we should get an echo. But I think the dog's probably just got, as Dr. Wall said, he's got a fat heart. So I need to lay off the food. I thought the cardiac the gastric access was a little bit too cranially positioned. That's something that I noticed that I tend to probably overcall, but it's not a deep chested dog like you would expect to have, and it's a Labrador. So maybe, I would say that this is small, could be normal for this breed. But given that it could be normal for this patient, but given the breed, maybe make sure that there's no chronic hepatitis. I think there's a bronchial pattern, but I think it's an old dog. There's a little fat mass right there that's ventral, and it probably corresponds to this little divot right here. Okay, so I think the chest is fine. Old fat dog chest. This one's the tricky one. Okay, so there is a mass that you will see right here. So if you look closely, what you'll notice is that right in here, there's this thing right here. It doesn't look like everybody else, and I'll outline it. So I think it goes from here to here, like that. Okay, so it's about a 17 centimeter swelling, right? Because this medial aspect of the crus, it should kind of go up like this, so this kind of bulges like that, okay? So, and I think it's back here, maybe here, and then so it's sort of cranial to the gastroc here. Okay, so first thing you could do is go, well, where's the mass? And if you can't find the mass, you go, all right, well, is there an aggressive bone lesion? I don't see an aggressive bone lesion. Maybe that's a little lip of OA on the lateral aspect of the tibial tuberosity. So then you go, all right, well, let's make sure the dog didn't blow a cruciate. And then you can kind of zoom. The delay. You zoom in here and then you say, yeah, I think this looks pretty good. Patellar ligament, infrapatellar fat. That's probably the menisci. Not probably. Those are the menisci. And then you look at the tarsocrural joint and that's smooth. So this swelling, yeah, so Dr. Walsh is using her Röntgen signs of metal, mineral, soft tissue, and fat. So that isn't, it's a large, presumably an intermuscular lipoma. And it's quite homogeneous, so it's probably not anything sinister like a liposarcoma. I bet if you did a CT, you'd see it as an intermuscular lipoma, but a CT could be nice because you want to make sure that it's not an infiltrative lipoma. Those can be a little bit nasty to dig out. So this is an intermuscular lipoma, a little more distal. Usually we get them up in the caudal aspect of the thigh between the semimembranosus and semitendinosus. Yeah, so I think what they did, so there's this question about that mass looks like fat. Yep, it's a fat opacity, not connected with bone for osteosarcoma and MET checks. So I think what they probably did was they just wanted to make sure of two things. One, they saw the mass and maybe they weren't able to ascertain that they thought it was fat opaque based on this. And so they were worried that it was soft tissue and maybe more sinister like a sarcoma. So they did the MET check. Two, they realized that it's fat and they're going to cut it out because it could potentially get bigger and cause the patient mobility issues. And so because it's a geriatric obese animal, they wanted to make sure there's no comorbidities like pneumonia, cardiac disease and so on, or METs from some sort of abdominal neoplasm that they're not seeing. So that's an intermuscular, or at least it's a pelvic limb lipoma. You guys did great. That was awesome. Those are tough cases. Those are super difficult cases, and I think you guys did really well to notice that was fat opaque. Okay, it's a great case right here. 3 views. So this is a okay, I'm just going to make it up. It's a screw tail animal, right? So it's a brachycephalic, so it's like a bulldog or something like that, and it's intact, and it's limping, and it's acutely limping, and they have decided to do three radiographs. Okay, 1, 2, 3. Okay, so trying to figure out why this middle-aged dog is limping. Good question, doctor. Which leg is it limping on? They think it's limping on the right pelvic limb. They don't think. He's fracture lame on his right. This is the thought process that I went through. Is I first, yeah, he has no hip. First thing I did was I saw the implants. That's from a tibial tuberosity transposition. And so I kind of zoomed in on it and wanted to make sure that it didn't look like there was any sort of complication. There's a lot of overlying soft tissue, so it's hard to say if there's any swelling associated with that. So whenever you see implants, you want to make sure, do we have any lucency around there? Obviously, we don't have the or the immediate post-operative radiographs to compare for any changes in orientation, but this looks pretty good. So I don't see any evidence. I'd be looking for things like lucency there's something called Überschwinger, which is an artifact. So if you look at that lucency right there, if you really zoom in, it's uniform and thin and contours the Kirschner wire very closely. Any sort of osteolysis related to loosening, migration, infection, it tends to be wider and irregular. With time, you'll get swelling, you'll get some periosteal reaction. So the implant looks great. But yeah, so one of the things I wanted to show you is you'll notice on the lateral view right here, you've got a crescent lucency, sort of crescent moon. Okay. And that is a femoral head that is nicely seated in the acetabulum. You don't have it here. So Doc Walsh wants to know, is that what we used to call leg cath perthes? And I would say no, it's not. This is a different process. So leg cath is the avascular necrosis of the femoral head / neck. And that usually causes necrosis of the neck. And so it eventually gets kind of loosened. And then the lucency progresses. Sometimes you'll get sort of an apple core look, but the animal will have a chronic it's a chronic or protracted course of lameness. And so when you sometimes see these patients, there is a fair degree of atrophy, disuse limb atrophy. So he's fractured the head of his femur. Okay, so this is his femoral head, and it's superimposed over the proximal femur, and it's not situated in here. That's probably a chip fracture. And so this is a femoral neck fracture. But I think this is, so this is, the femoral head is hiding here. But one of the things I think to draw your attention to is, which leg do you think, well, that's not a great question. If you look at the soft tissue coverage of the pelvic limbs, which leg has more muscle atrophy? Is the left. I do think there's maybe some swelling here in the fat, but the left pelvic limb has a little bit of disuse muscle atrophy, maybe related to this. And so this does support, what you want to do is, when you see a fracture like this, you want to decide, is this an acute thing or a chronic thing? So the chronic, you'd see muscle atrophy, you could see some remodeling. This is acute, and it supports the history of acute because the soft tissue coverage is great. The dog was using its leg, and then it wasn't. And then you look for these margins of the fracture are very sharp. So there's no resorption. Usually in the initial days that you'll get resorption of the fracture margins and so on. And then that'll eventually progress to, a non-mineral opaque callus, and then a mineral opaque callus, and so on. So this is an acute fracture of the femoral neck. And I suspect that it was traumatic. It is traumatic because it's not pathologic. Because there's no degradation of the bony quality. So it's got some discs here, right here. There's a bad disc. That's probably a bad disc. But yeah, this is an acute traumatic fracture of the hip. So when we talk about fractures, I used to think everything was traumatic and everything was acute. So you want to be careful that is it an acute or a chronic fracture? Is it traumatic or pathologic? So pathologic would be from some sort of metabolic bone disease, like osteogenesis imperfecta, or secondary hyperparathyroidism, or something that's caused the mineral opaque quality of the bone to be poor, and then they put normal stress on it and it fractures, or if you have a bone tumor and it fractures. So this is an acute one. It's traumatic, and that's the cause for the lameness. 1, 2. Okay. So 1, 2. So first thing I do is I just get all of these set up in the right orientation, kind of like that, and kind of like this. And okay. And then we also want to make sure that's a left, that's a left, that's a left, that's a right, 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 and right. So there are 4 rights, 3 lefts, all of the thoracic limb. And this history is the patient has lameness, and they can't tell what leg he's lame on. And he seems kind of punky. Okay, so you guys are all on the right track, in the sense that when you see these radiographs and you see these physes, your brain should start thinking, well, what are the common diseases that these dogs get? And so you start thinking things like hypertrophic osteodystrophy. You start thinking about things like osteochondrosis dissecans, Panosteitis. Metabolic bone disease is much less common. So this dog, I will show you the problem in this dog. So a couple of things to point out. This bit of sclerosis right here is normal. This physis is normal. The humeral head is also very smooth, so there's no OCD on this. Okay, this elbow, the other thing you could look for is elbow dysplasia. This is such a nice looking elbow. Anchineal process. There's no subtrochlear ulnar sclerosis. It's very congruent. But this right here, this patch of love is not normal. Okay, so that, what you can do is you got cortex and medulla, and you should see that distinction. You kind of lose it up here a little bit, but that's way too opaque. It's probably too much down here as well. And then did anybody see it? It's right there. They call it thumbprinting. So it looks like you took your thumb and you just went boink. Yeah, it's probably in here. This is more of a vertical striation, which I don't as commonly seen. I thought maybe that there was a retained cartilage core, but I don't really think there is. I think that's just it could be associated with panosteitis, but panosteitis tends to be more patchy. Medial coronoid is totally fine, very normal right there. So this is panosteitis, and when you squeeze on that area, they don't like it. Cool case, some pano. It's real. This used to always bother me. This subchondral, or sorry, this subjacent metaphyseal sclerosis, and it's totally fine. So tell me, isn't that only on ulna? Isn't what only on the ulna? The retained cartilage core. That's a good question. I don't know. I don't know the answer to that. I feel like you are correct. I feel like the more times I have seen it, it's that sort of radiolucent triangular structure that does originate from the ulna. But I guess I wouldn't know why it couldn't affect the radius as well. Yeah, I think the dog is bilaterally lame, and so that was some of the confusion. I'm sure a lot of you have seen the panosteitis dogs, but they sometimes, some owners have brought them in and they say that they thought the dog got hit by a car. They're just painful. They're screaming. They're painful all over. It's hard to localize. So I think this dog, and if you took other radiographs of other limbs, you may see it as well. So sometimes they're not always lame where you see the lesions compared to where you see other lesions. Okay, here we go. Recently adopted older dog. Owners worried because they felt some sort of large mass on the dog's body wall. 1, 2, 3, 4 reds. Right lateral, VD, left lateral. Anybody see anything rotten in the state of Denmark? So the cardiac silhouette, I agree, it does look kind of small on this radiograph. It doesn't look small on that VD view. We know it's a VD view, right? Because it's got the 3 humps. 1, 2, and then kind of 3. We always say Mickey Mouse has VD. I don't know if that's funny or if I can say that, but you could go like this. You go boink, and then you could do like this. It's supposed to be perpendicular. I know that's not. And so then what you do is you collect your cute numbers. You go 1, 2, 3, 4, and you drop this over here, and you go 14.65. 14.65, sure, it's close enough. 10.4, and you do like this, and you go, this Dr. Buchanan from the good old days came up with this 2, 4, 6, 8, 10 point whatever. So no, it's normal. So you do this sort of enough times where you subjectively think something's one way, and you use a little bit of an objective, some objective criteria to back off. So the cardiac silhouette's fine. Can't get my eyes off the masses on the ribs. There are masses on the ribs. And I like that you said masses. There are masses, plural. Okay. So I also like that you didn't, some people, one of the pitfalls that you make if you're starting out or interpreting is you try to diagnose the disease sort of instantly without going through the process of, okay, is it normal or not normal? This radiograph is abnormal. And where is it abnormal? Well, there's clearly this thing. So what is that? 1, 2, 3, 4, 5, 6, 7, 8 left, 8th rib. But there's also 1, 2, 3, 4, 5's not normal. 6 is not normal. I don't know. Maybe there's something there that's not normal. Okay, so you've identified, let's say you just didn't believe me and you're like, there's nothing there. Okay, maybe you can see that, at least on the lateral view as well. You can see that, there's probably something there, there's something there, there's something there, there's this big one. Okay, so then you go, okay, so I've got these masses, and then you go, well, what are the masses? Are they soft tissue, mineral, fat? These are mineral. So you got mineral opaque masses. And then your next thought is, okay, so if I've got a mineral opaque mass, your next sort of algorithm down is to go, is this a benign or malignant process? Or rather, is it a benign or aggressive process? And so this is multiple cartilaginous exostoses. And so once you see it once or twice, you'll just kind of always remember it, and it won't be an issue for you. But if you haven't seen it, you get it inflicts a bunch of panic. So what you need to take away from this is that this is a benign lesion. So some of the criteria for malignancy are zone of transition. This is very abrupt. I can see it. The degree of periosteal reaction. So is there a irregular periosteal reaction, which would suggest, and is there any lysis? And is it cortical or medullary lysis? And this looks very cute and smooth and sort of, even though it's got a bit of an amorphous shape, it's somewhat round and it's sort of expansile. And so this would be classified as a benign bone tumor. And when you've got multiple ones, they usually originate from metaphyses, the metaphysis where the growth is occurring. Sometimes they can get pulled up into the diaphyseal portion of different bones. But these tend to be no big deal. They tend to stop growing when the patients reach maturity and the physes close down. There have been rare reports of them transforming into osteosarcoma. So with this particular case, I said, look, probably not a big deal. Maybe just periodically take rads or palpate them to make sure that they don't cause any discomfort. The spleen's kind of chunky. But that could be sedation if they gave them some sedative. It could be extramedullary hematopoiesis. When you see a splenomegaly, you go, okay, if I don't really think that it's lymphoma because the liver's not big, it could be sedation. It could be extramedullary hematopoiesis because it could be lymphoid hyperplasia if they're young, but they're not. If the dog had IMHA or ITP, it could be sequestering blood vessels. So the dog's got a bronchial pattern. Again, we talked last time, bronchial patterns are like assholes. Everybody's got one. This dog wasn't reportedly coughing. He's old because he's got some spondylosis deformans, and he's just got kind of a ratty looking lung pattern. So I think that's why you see enough of these lung patterns. You go, the dog's coughing, and then you look in the history and there's no coughing, and then you're like, all right, I give up. So multiple cartilaginous exostoses. Could you differentiate this from calluses on the ribs due to previous trauma? How would it look different? I so rarely comment on costochondral junctions. They do the weirdest things. They mineralize. Sometimes they sort of bellow cranially if the patients have a chronic upper respiratory problem. So I think it can be hard if you were trying to differentiate some mineralization of the cartilage from a fracture. I think if you really wanted to get down to it, most fractures involving one of these costochondral junctions, what are the chances that it's going to heal in such a nice in such a nice sort of manner where it's aligned and well opposed, especially if the ribs are constantly undergoing motion from respiration. So I see a lot of crunchiness, a lot of mineralization near the junction. I see that a ton, and I don't really get too freaked out about it. So I don't know if that helps. I do think some of this spacing, I mean, he's got an extra pleural sign, so this is pushing inside the chest, and I do think it's causing some crowding issues and some abnormal spacing from that large exostosis right here. But I doubt this is clinically relevant because it's not near a joint, it's not near the spine. It's, there are intercostal ribs and blood vessels, but it's just gently pushing them out of the way. It's not invading them or irritating them. So, yeah. Does the spinous process 7-8 look normal? 7-8. 1, 2, 3, 4, 5, 6, 7, 8. This is sharing a room with your sibling. You're just angry all the time, and you've got a little, that could be an exostosis kind of coming off the back there, and now somebody's got to give. And so you just sort of take the pressure from this bony protuberance, but we use the same thing. We go, all right, this is normal, not normal? It doesn't look normal. It doesn't look like most everybody else here, so it's kind of standing out, and it's creating a concave defect along the cranial cortex of this one. But boy, that's so smooth. What kind of cancer just gently, benign ones do. So they just gently push. So if this was some sort of, neoplasm, then I would expect this is a non-aggressive. I think I'm making it more complicated. This is a non-aggressive osseous lesion. And I think you should just sort of not worry about it. There's probably an exostosis coming off of L1-2, which could be clinically relevant, although it's coming off the ventral aspect of the body, so it may not be impinging the canal. Okay. But let me do one more. I had a request for, we had some requests for musculoskeletal, and so I'm going to give you 2 rads, okay? Well, maybe a couple of rads. I want to give you a couple of rads, but they're going to focus in on the tarsus, and then maybe if we have time for one more, then we'll call it quits. So we have a right pelvic limb. Okay, so I'm going to focus in on this. So this study is going to be right pelvic limb and left pelvic limb. This is a middle-aged dog that is severely lame in its pelvic limbs. Yeah, so we've got a tarsus. Maybe there's a fracture. Some periosteal reaction, lucency around the tarsal bones. We've got a vote for tarsal osteochondrosis coming from Croatia. That beautiful blue Adriatic Sea, I think, right out there. This is new bone growth on the plantar aspect of the left tarsus. Patchy bone density, so soft tissue swelling around the joint, loosened areas around multiple joints. Looks polyostotic. So we've got some people voting here. So I'll show you what I do. So the first thing that I did is I like to eat my food eat all your vegetables and then your meat, and then so I eat everything together. So I kind of go through these one limb at a time. Okay, so on the right lateral view, first thing I did was I looked at the stifle joint, and I said, "Man, that looks pretty normal." This is a great place to look for problems in the stifle. So this is fat within the gastrocnemius. This is gastrocnemius, fat within this fascial plane. And when the joint swells, yes, you get the loss of the infrapatellar fat pad, but it also blows this out caudally, fluid synovial hypertrophy or hyperplasia rather. Okay, so this is, I think, obvious. We all go, well, this is a bony thing that's not in a little bony structure, mineral opaque structure that's not in the right place. But this is swollen. That shouldn't look like that. A great place to look for tarsal crural swelling is on the plantar aspect. You'll get a little poof out here on the plantar aspect. This is a lot, but usually you get a little. So this is a periarticular new bone formation. That's the joint margin. Okay, this is probably a little bit of OA on the tarso-metatarsal joint. But here you've got this mineral body along the proximal and plantar aspect of the tarsocrural joint. This doesn't look particularly congruent, but I wouldn't expect a lot of people to make a lot of judgments on that. But when you look at this view, you want to look at the medial and lateral ridges, and there's a line right through here. And so this is a osteochondrosis lesion of the medial trochlear ridge. And we know a lot of times with osteochondrosis, it tends to be a bilateral. This is really swollen. I mean, this thing is pissed. And there's OA right there. And this is a mess. So this looks like could potentially even have been a chronic fracture. It's so bad, but it may have been really bad osteochondrosis, and the integrity of that medial trochlear ridge is really bad. So this is, had I just had this and not the other leg or a history of the other leg, I think you got to be a little bit careful because this is so bad. But there's widening of this joint space, which you're not usually supposed to comment on a non-weight bearing study, but this is wide. There's all this new bone formation, and this is chronic. So there's a lot of swelling. This is really swollen. There's a lot of periarticular new bone formation. And so what happens is with time, these just this is probably a joint mouse, and it's just kind of wandered around. It could potentially be dystrophic mineral of the flexors. But this is, I think, and this is, I think, what Dr. Curtin was saying. There's mineral new bone formation superimposed over this calcaneus. What breed is it? I don't remember. Can I just say it's a German Shepherd? It may be actually a German Shepherd. Okay, maybe a German Shepherd. What part, Tom? The fibular head? It's right here. I hear what you're saying on this, on the craniocaudal view, especially this first one, that it does look like it's in a different room. But let's see about this one. Looking at this fibular head, Dr. Walsh is, this one looks a little bit more normal. But then when you compare the lateral views, the right and the left, it's probably in the same spot. I don't know, man. I guess I'm hard pressed to say that it's luxated because it really looks like it's in that spot right there. And on the other view, it looked like it would have been either cranial or caudal. So I think we're probably okay. I don't see any lysis in any tarsal bones. There was some concern about lysis in the tarsal bones. This stuff right here, let me go through some of these comments. The distal fibula, I think it's okay. That malleolus, the lateral malleolus, or the little hammer, I think it's Latin for little hammer. I see it right through here, and it's situated right there, so I think it's okay. Concerns about tarsal bones. So I think I would describe this as sort of coarse trabeculation, and this is what I would expect to see. You could kind of see it here as well. Maybe not so much there. Maybe there. Some of it could be technique, but I also, the dog's been lame, so there's probably some disuse osteopenia happening to those bones. See the hips, crescent right there, crescent. Those suckers are locked in. Okay. Don't forget the redheaded stepchild of musculoskeletal is the soft tissue. So these pelvic limbs, there's hardly any. I mean, these are so atrophied. But one of the things I wanted to show you as well with the hip joints, does anybody think the hip joints are normal, not normal? What do we think? Not normal, not too bad. Normal. So these are not normal, but not too bad. So I'll show you a couple of areas to look out for. So this structure right here, it's a very thin structure that's curving down like here, and you see one kind of right here. It's called a caudolateral curvilinear osteophyte. It's not an osteophyte, so it's a misnomer. It's an enthesophyte with joint capsule attachment. This doesn't look like much, but on histopath, there's chunks of bone. So that indicates that there's some degree of laxity. The femoral head, it's very smooth, and it does have adequate coverage of the, here's the femoral head, and the acetabulum, the dorsal rim sneaks through there. So it's really covered. But it has a caudolateral curvilinear osteophyte. This is called a circumferential femoral head osteophyte, or a CFHO, and he's got them on both. So these two in combination with the breed suggests that there is some degree of hip laxity, but yeah, certainly not bad at all for a German Shepherd. As far as the question for rotation of the pelvis, I don't tend to look at the obturator foramen. What I usually look at is the ilial wings. So the way that it's been explained to me is that it's not fat shaming, okay? So nobody cancel me, but thin is in, okay? So I was taught that whatever ilial wing looks thin, the ipsilateral or same side femoral head looks more covered, and thus the opposite looks less covered. So thin is in, okay? So I think we can all see, it's a fairly well-positioned VD pelvic radiograph, but this wing it's flaring out a little bit more. So when you compare these wings, this one's kind of thinner, this one's a little bit thicker. And so if this one's thin, then when you look at this hip, you should go, oh, that one's artificially increased coverage, and this one has artificially reduced coverage. I think that's about that. That should about wrap it up. I've got a sick child at home, and I'm coming down with a cold as well. You guys been a lot of fun. We're going to edit this up, throw it to YouTube so you can have it. Cheers, guys. Email me. My email is pnoel@parallax.vet. And you can send me emails, but I think it could be fun if you guys want to bring me some of your cases, try to stump the chump. I think that I like being put on the spot. Some of this, this keeps me sharp as well. So, but I'm having fun. Looks like almost 20 people stayed for the end. So it's great. All right, guys. I'll talk to you soon. Ciao.